Getting shot by a Nerf gun is all fun and games, but PTSD and the traumas involved are quite the opposite. In our world, these child traumas are somewhat commonplace. Just as a present example, there are over 2 million Syrian child refugees. These children have been traumatized by war, by leaving everything they know, by sexual assault, by potentially countless other tragedies. Understanding and treating pediatric PTSD is a crucial step in ensuring that these traumas don't continue their harm. The DSM-5 includes a separate diagnostic criteria for PTSD in children under 6. This is because children have a lower ability to verbalize their thoughts and feelings, which means there needs to be more of a focus on behavioral symptoms in the criteria, like recreating the trauma during play. Children also have less of a cognitive ability to project oneself into the future, so they may show less anxiety-related symptoms. The first diagnostic criterion is experiencing, witnessing, or learning of a traumatic event. Additionally, there must be the presence of intrusive symptoms like recurrent involuntary or intrusive memories. There must also be alterations in arousal and reactivity, like an exaggerated startle response. There also must be one or more persistent symptoms of avoidance of stimuli or negative alterations in cognition. In children under 6, these negative cognitions may be expressed as an increase in negative emotional states like fear, guilt, sadness, shame, or confusion. The avoidance symptoms could simply be refusing to return to places that remind the child of the trauma. This symptom is consistently negatively reinforced. These symptoms must last more than 1 month. There must be distress or impairment in relationship with friends or family or with school behavior, and the symptoms can be due to a substance or other medical condition. Here we can see a chart of the PTSD symptoms in a study of 130 burn victims younger than 6 at 1 and 6 months after the accident. The most common symptoms at both times were nightmares, psychological distress from reminders, active avoidance of reminders, sleep disturbance, and irritability and temper tantrums. It is also important to note that when possible, the best assessment method as a clinician is interviewing or observing the child directly, because parent report questionnaires consistently underreport PTSD. Children under 6 may also show psychosomatic symptoms of PTSD, like headaches or diarrhea. So what causes all these symptoms? A necessary criterion in PTSD is previous trauma, but it would be overly simplistic to say that PTSD is just caused by trauma. PTSD is caused by a complex, multidirectional interaction between characteristics of the trauma, biological and psychological characteristics of the child, and characteristics of the child's environment. Multiple studies have shown an association between PTSD and genes that affect dopamine regulation in children under 6. One particular study has shown that race moderates the influence of a certain genotype on PTSD. 171 children aged 3 to 6 and exposed to various forms of trauma participated. Every single African American child with a certain catechol O methyltransferase genotype was diagnosed with PTSD, and not a single European American child with a genotype had PTSD. This suggests that the genotype can be either a vulnerability or a protective factor. The studied allele has been shown to cause decreased dopamine turnover in the synaptic cleft, especially in the prefrontal cortex. However, researchers are unsure what sort of gene-by-environment interaction is responsible for the disparate associations and recommend interpreting the results with caution. Biologically, acute traumatic stress activates the locus coeruleus in the sympathetic nervous system. The sympathetic nervous system prepares the body physiologically for the fight-or-flight response, as the locus coeruleus stimulates the amygdala, which releases a hormone stimulating the HPA axis. This leads to a release of cortisol and intense arousal. It is theorized that dysregulation of this biological response and maintained arousal are in part responsible for PTSD. One study supporting this arousal hypothesis showed that increased heart rate 1 day and 7 days after a traumatic burn accident in children under 4 was associated with more PTSD symptoms 6 months later. Additionally, this increased arousal may result in a higher level of fear conditioning of the trauma, which leads to more attempts at avoidance and thus more PTSD symptomology. Many studies have looked at the role of the child's maternal relationship and mother's mental health in the development of PTSD in children under 6. From a psychological attachment perspective, it is theorized that the moment of trauma violates the child's assumption that the mother or his or her other attachment figure can protect him or her, which is a key foundation of secure attachment. Then, after the trauma, the child's risk of PTSD can be attenuated by the degree to which the caregiver can respond effectively to the child's needs. This is supported by a study of 232 Israeli children under 5 who were exposed to daily war-related trauma. Those with PTSD showed more avoidant attachment patterns, and secure attachment was associated with lower rates of PTSD. The mother's well-being and sensitive behavior toward the child were associated with more child resilience. Another study showed that maternal PTSD symptoms, maternal avoidance coping, and maternal emotional sensitivity were significant mediators of the child's symptoms of PTSD after a life-threatening traumatic event. That is, the trauma led to the mother's symptoms, which affected their relationship to the child, which then led to the child's symptoms. Other studies show relationship between maternal mental health problems like depression and PTSD and the child's PTSD as well. The association of mother and child symptoms likely involves genetic, environmental, and social interactional influences. An obvious environmental influence on the risk of a child under 6 developing PTSD is the trauma itself. As mentioned earlier, a significant traumatic event is a necessary criterion of PTSD. One study showed that young children exposed to more than one traumatic event are more likely to develop PTSD than those exposed to only one. An amount of trauma exposure has been shown to fully mediate the association between sociodemographic risks and PTSD. The specific type of the child's injury may not affect a young child's likelihood of developing PTSD, but trauma involving threat to one's caregiver puts children at an especially high risk. Psychologically, a higher perception of uncontrollability, threat, and sense of fear during the trauma lead to a heightened risk of PTSD. There are no consistent results for gender being a risk factor in developing PTSD after a traumatic experience. What's the course of PTSD in children under 6? After experiencing a traumatic event, children may show resilience, which is not developing PTSD or acute stress disorder. They may recover from acute stress disorder or PTSD, or they may have a chronic course of PTSD. Hence, PTSD can't be defined as having any one type of course. For a subset of children, the effects of trauma follow a chronic and unremitting course. These children, without treatment, show problems with emotional, social, behavioral, and even physical development later in childhood. These long-term developmental effects are what is especially concerning about cases of PTSD in children under 6. Studies have shown that in children under 6, PTSD is even more likely than adults to follow this chronic course. We can see in this study, which followed children for 2 years under 6 with PTSD, that their mean number of symptoms decreased by less than 1 over the 2-year period. This increased risk of unremitting PTSD may be because in young children the neurobiology of their brains is still actively developing and may be critically developmentally affected by the trauma. Maintenance of PTSD after 2 years has also been shown to be mediated by maternal mental health characteristics. In another study of child burn victims, age, gender, severity of burn, and even child trauma history were shown to have no significant effect on the course of PTSD. However, the number of post-traumatic symptoms at 1 month do significantly predict the course of the disorder, with more post-traumatic stress symptoms predicting a chronic course. So what are the treatment options for children 6 and under? Unlike with adult PTSD, there is very little research on the use of pharmaceuticals to treat PTSD in preschool and younger age children. The brain is quickly developing, and due to the risks of long-term side effects, psychopharmacological interventions are not recommended for children 6 and under. Despite this, however, over 50% of physicians report using SSRIs for preschool-age children. There have been case studies for young children using risperidone and clonidine, which are drugs that have been used to treat adult PTSD. While the results were encouraging, there have been no clinical or randomized trials of the use of these drugs in children under 6. A literature review showed that pain associated with the trauma was associated with more development of PTSD symptoms, so the researchers posited that using opioids to reduce the pain soon after the trauma may prevent development of PTSD, but there is no published research on this topic. Overall, there is currently too much risk and not nearly enough evidence to suggest that drugs should be used to treat PTSD in children under 6. Preschool trauma-focused cognitive behavioral therapy and child-parent psychotherapy are the 2 treatments for childhood PTSD with the strongest evidence base. While preschool trauma-focused cognitive behavioral therapy includes graduated exposure, coping skills training, and psychoeducation targeting the symptoms of PTSD through methods typical of cognitive behavioral therapies, child-parent psychotherapy focuses in on the child's attachment relationship to his or her mother or caregiver. It is based on the attachment hypothesis posited earlier on the cause of PTSD, working with the belief that a child's attachment system is the main organizer of his or her response to danger. Preschool trauma-focused cognitive behavioral therapy was developed with the same problem-solving and skill-based approach used in many adult cognitive behavioral therapies. Child-parent psychotherapy was developed specifically with the developmental importance of attachment for children under 6 in mind. It works to empower the mother to be an ally to the child as he or she copes with the trauma. These 2 therapies have not been directly compared in a study, but both have strong evidence of their efficacy. A follow-up study of preschool trauma-focused cognitive behavioral therapy showed that the child's mother's depression symptoms were associated with a relapse 6 months after the event. Yet, a follow-up study of child-parent psychotherapy showed that reduction in PTSD from child-parent psychotherapy was durable and maintained 6 months after the therapy. Depression may have harmed the mother's relationship with the child after preschool trauma-focused cognitive behavioral therapy, while the relationship-building focus of child-parent psychotherapy may have attenuated this issue. It would be important for future research to compare these 2 treatments directly and examine factors that predict the outcomes of each of these, whether that be the factors of trauma, the child's biology, the mother's mental health, or any of the other risk factors for development or maintenance of the disorder. Young childhood PTSD may affect generations of our world's children, but it still lacks the thorough research literature of many other mental health disorders and of PTSD at different points in the lifespan.